gentlemen, thank you for standing by, and welcome to the AIA teleconference on understanding fetal alcohol spectrum disorders. Your host today will be Jean Peterzak. During the presentation, all participants will be in a listen-only mode. Please go ahead, Ms. Peterzak.
Thank you very much, operator. I'm very sorry for the slight delay that you all encountered, but I do want to welcome all of you to today's training on fetal alcohol spectrum disorders with our esteemed guest presenter, Dr. Claire Coles. We're very happy that you joined us today. My name is Jean Peterzak, and I'm the director at the National Abandoned Infant Assistance Resource Center at the University of California, Berkeley, funded by the Children's Bureau. Our goal and mission is to enhance the quality of services provided to children and families affected by substance abuse and/or HIV by providing training information and resources such as these kinds of calls to professionals who help the families. So welcome again to this AIA live webinar. I just want to tell you that the webinar will be 90 minutes long, and Dr. Coles will have an opportunity to discuss her research and expertise on this issue, and I'll be prompting you during the Q&A sessions. So the title of this call is Understanding Assessment, Diagnosis, and Treatment of Fetal Alcohol Spectrum Disorders. I wanted just to give you a couple of logistical pointers about how the call will work, and please don't worry because the operator will be back on to assist people during the Q&A time. If you experience any problems and need to speak with the operator individually, please dial *0. To be placed in the Q&A queue during the webinar, if you're using the webinar portion, use the chat box and send it to the host. During the designated times for Q&A, I'll be addressing those questions to Dr. Coles. If you're logged in only through the audio phone, there will be intermittent Q&A periods throughout the webinar, and the operator will prompt you how to queue in for those questions. So without any further ado, I would like to introduce our speaker here. And I will basically give you the short version of her lengthy expertise. Dr. Coles is currently the director of the Fetal Alcohol Syndrome and Drug Exposure Center at Marcus Autism Center. She's a professor of psychiatry and behavioral sciences at the Emory University School of Medicine in Atlanta, Georgia, with a joint appointment in the Department of Pediatrics. She has been a member of a number of important national task forces on fetal alcohol syndrome and fetal alcohol effects throughout these past years. So Dr. Coles, I think at that, I would like to turn the call over to you and have you take it away.
Thank you. I'm happy to be talking to all of you today and to be working with your fine organization. I think I actually once worked with you before in writing a article for your journal, which was a nice experience.
Source. Yes, that's true.
Source. Mm-hmm. Today I'm going to talk about a topic, understanding assessment, diagnosis, and treatment of fetal alcohol spectrum disorders. And we decided on this topic based on the requests of a number of people in your program who are interested in knowing about specific areas that were related to these questions. I'm going to be doing more of an overview of this rather than talking about specific research data, but I'll be happy to go into anything in more depth if you're interested in that, and if you would just go ahead with your questions in terms of the chat or the question and answer period. As was mentioned, I am a part of the Department of Psychiatry, Behavioral Sciences, and Pediatrics at Emory University School of Medicine, and we have been conducting research on the effects of alcohol in pregnancy since about 1980. We have a number of longitudinal cohorts of individuals who were exposed to alcohol, to cocaine, and to tobacco during pregnancy that we've been able to follow over time and learn a great deal about their life history and the kinds of effects that these substances have had on them. In addition, I am presently the director of the Fetal Alcohol and Drug Exposure Center at the Marcus Autism Center, which is part of the Children's Healthcare of Atlanta. This program allows us to provide treatment and diagnosis and treatment to alcohol and drug-affected children. We began this second program after doing research for some time in the field because it was very clear to us that there was a great need for actual diagnosis and treatment, not just studying people. So that's more or less how we got into everything. Today, I'm going to be talking about several things. One is assessment, which has to do with how do you, as the person working with a family, decide that there's a need for further intervention. This would involve screening families and the child's behavior, interviewing birth mothers about alcohol and drug use, and deciding when you should be referring this child for more treatment. If you do make such a decision, you then are faced with the question of how do I get a diagnosis and find out whether or not what I am seeing is in fact related to the effects of alcohol or drugs on the child. So where do you refer this child? Who is qualified to make decisions about the effects of alcohol and drugs? And what sorts of things go into the diagnosis that help the professionals understand the problems that they're seeing and what kinds of recommendations to make? Finally, as part of the diagnostic process, most professionals will provide a number of treatment suggestions or referrals to other organizations or professionals in order to provide services. That raises another important question, and that is, well, are there any specific treatments for FASD? Is there a standard of care which has been developed for this disorder? How does one access resources that allow you to get appropriate treatment? And what do we know about the kinds of treatments that are effective in individuals who are alcohol and drug affected? To begin with, as I think all of you are probably aware because of the work that you do, there are a number of women who continue to use alcohol and drugs during their pregnancy. And I like this chart, which comes from the Centers for Disease Control and Prevention, because it sort of points up how important it is to consider alcohol and cigarettes when you're thinking about the effects on the child of the mother's substance use. This is particularly important because we often find ourselves paying attention to illicit drugs, and the newspapers and the legal system and so on is very concerned about illicit drugs, and of course it should be. But when you look at the number of people who are using those substances or report using those substances in comparison to those who report using legal drugs like alcohol and cigarettes, it has to be very clear that this is a greater problem, the result. And then the other issue, of course, is that alcohol probably has more effect on the fetus than any of these other substances have been shown to have. Another important issue is how frequently does alcohol use by women of childbearing years occur. And I think I like this map also from the CDC that talks about how much of a problem alcohol really is for women. And I think you can look at your own individual state, and I guess you guys are in California, so you can see that you have about 43% of the women using alcohol and 12% binging, which is to say using 4 or more drinks per occasion. We know that many of the women who use alcohol during their childbearing years continue to use that when they're pregnant. We also know that about half of all pregnancies are unintended, and therefore it is highly likely that women are exposing children during the beginning of pregnancy when they may not even be aware that they're pregnant. One of the things that I always like people to do is take a clear look at where you came from on this map and see what the use is like. And it turns out that the further north you are, the more you use alcohol, it appears. And I think that has to do with cultural factors and sometimes religious beliefs and so on. And I think that that's an interesting phenomenon that is important to bear in mind when you're thinking about who you're interviewing and what their particular habits are. Now, let's say that you have decided that you are concerned about a family, or you're working with a family and you need to consider this as an issue. Many people, and this may not be the case for some of you who are listening because you already are working with substance-using families and you have a lot of expertise in interviewing women and talking to them about their use. But I always think it's helpful to remind people that you need to ask the question. Sometimes people, even though they intend to interview people about their substance use, don't really ask the appropriate questions, and they don't feel comfortable in asking them. Several of the things that I ask people to think about when they're proposing to investigate this issue are, remember that the people who are drinking and using drugs are aware that they're drinking and using drugs. They should not therefore be offended to be asked about it, and they certainly won't be surprised. And it may be that if the person is not using, they're going to be surprised, but certainly if they are, this is no shock to them. Another question that comes up frequently is if you are finding it difficult to ask these questions, you need to understand why that is uncomfortable for you to do. And I have met many people who were working in the field or professionals that had a family history that involved some substance use or difficulties in this area, and they often had very complex issues in approaching these questions, particularly with women who were mothers. And I think it's important for you to be able to understand whether or not you are bringing anything into the conversation yourself. And finally, if you feel uncomfortable asking questions of mothers about their use during pregnancy and are disinclined to do so, even though this may have occurred, you need to keep in mind that the child is the person who will be harmed by not asking the question, because the child needs to have an intervention. The child needs to get on the best possible path in terms of their development. And if we do not ask questions about whether or not they're exposed and how this is affecting their development, then the child will not get the help that they need. Another important topic is, how do you ask the question, and how do you discuss the problem of alcohol pregnancy? For instance, people often ask, I had a research assistant once who was out interviewing mothers that we were working with, and she was going, when the child was about 6 weeks old, to the home and asking a little bit about what went on during pregnancy. We'd already asked and we knew about it, but this was just to confirm. And it turned out she didn't feel very comfortable about it, and so and I guess we weren't supervising closely enough, because this is how she was asking the question. You didn't drink when you were pregnant, did you? And of course they all looked at her and went, no. And that sort of brought very clearly to me how the way we ask a question is going to determine the answer. So you are much better off being more concrete when you're talking to someone and more down to earth. So instead of saying you didn't drink when you're pregnant, you should say, how many times a week do you drink beer or wine or vodka or whatever it is they drink? And when you are drinking beer, do you usually drink a whole six-pack? Now, probably they'll say no, but then they'll tell you, no, I only drink 2. And that will give you much more information than simply asking them vague general questions that can easily be denied. Another question that often is difficult for people is finding out how long or how many months during the pregnancy the individual drank. So many women will say they stopped drinking when they became aware of their pregnancy. It's important to make sure that that's the case. For instance, you need to ask, well, when did you know you were pregnant? And some people will say 6 weeks, and some people will say, oh, well, I didn't really know until I was 6 months. And I went to the doctor, and so on and so forth. And so they may have very different perspectives on the answer to that question. And many people, for instance, will say they stopped drinking they didn't drink during their pregnancy, but what they mean is that I didn't drink once I knew I was pregnant. So they are ignoring the period of time before they were aware of the pregnancy. These are all things that need to be discussed, and they need to be discussed in a very calm, frank, down-to-earth kind of way so that the mother feels comfortable answering. The next question is talking about the child. Now, obviously, and we had one other slide in here which we took out, which sort of described the families in which substance abuse is likely to be a problem. I believe that the organizers felt that this was old news to the audience, so I really won't go into that. But there are some families, certainly, in which we are more likely to feel concern about the possibility that the child was exposed prenatally for a number of reasons. However, that just because the child is exposed or just because there's suspicion of that does not mean the child is affected. So one of the things we need to be very concerned about is learning how the child is doing. How do you ask the questions about that? Well, here are some of the things that I always ask about when I'm talking about the child to the mother. How is he sleeping? How is he eating? Is he learning to talk? Usually you say that not quite that way, but you ask about how many words the child can say, whether the mother thinks he's talking as well as the other children, or if they're older, how are they doing at school? Just in order to get a picture of what's going on, many times we find that the children who are alcohol exposed or drug exposed have problems with eating. They have problems with sleeping. They are slower to learn to talk. They have difficulties at school. So having issues in any of these areas are red flags. Another important question is the child's health. Are there a lot of medical issues? Is he sick a lot? Otitis media, for instance, or ear infections are extremely common in children who are alcohol and drug exposed, and also are really, really common in children whose parents smoke. Has he ever gotten hurt? Now, that's a very important question because in families where substance abuse is a problem, children frequently are not supervised closely, and the child may very well have injured themselves or been hurt, or, unfortunately, they may have been abused. Having to go to the hospital is a similar question. If they've gone once, that's not usually an issue, but when you find the child's been in and out of the hospital a great deal, that's probably a concern. Another question is, how does the child get along with other children? And that raises the question of whether they're developmentally normal, whether they're socially appropriate. Are there discipline problems? And then you usually get into the question there of the child's behavior, and the parent may feel that the child's behavior is hyperactive, or often they think of the child as bad, or they're having a number of problems with controlling their behavior and don't have good skills in terms of discipline. Another question we ask is, has the child ever been seen by, it's called Child Find in Georgia, but it involves the agencies that are concerned with children at risk. Is the child in special education? Does he get any kinds of services through the system? And finally, I always ask the parent if they have any concerns about the child. And they usually, if there is a reason to be concerned, the parent is aware of it and will tell you. When you've had a chance to talk about the child and talk to the mother about her situation, then you have to decide whether or not you should refer this child on to more extensive evaluation. Generally speaking, and this is sort of a simplistic rubric, but it's the truth, when the parent is concerned about the child, when the doctor is concerned about the child, or when you, the observer, are concerned about the child, it may be a good idea to refer them. It is generally the case that the parent and you will be more concerned about the child than the doctor will be. Doctors frequently say, well, he'll grow out of it, or boys are like that, or they all learn to talk later, etc. And, of course, a lot of pediatricians do not have time to spend really getting to know and understand how the child is doing. And so they have a tendency to sort of slide over these things sometimes unless they're extremely evident. So generally speaking, when the doctor is concerned, there's a lot of reason for concern. And parents usually know their children well, and unless the mother is in some state of denial, she will usually be aware that it's a problem. Finally, when you're concerned, obviously that's something that should be taken care of. I am concerned when a child presents with certain types of behaviors, and these are the things that are red flags to me. Delays in development of speech. And this is something we usually pick up in the second year of life when the child is between 12 months and 24 months. And there are certain kinds of patterns we should see in the child's speech at this time. And if we don't see them, then we need to do something about it. Now, parents, again, usually pick this up. They will maybe till the child's 18 months old or so not pay attention, but usually by 2, they're saying, he's not talking as much as his brother, or I noticed that his cousin is talking a lot more, and I'm worried about it. So you really begin to see language issues. Abnormal social behavior, if the child is not appropriately interactive with other children, if they don't try to play with their brothers and sisters, or if they refuse to interact with other people, or if they're extremely frightened of adults, these are all red flags. Motor abnormalities, the child's not walking when they should, the child's not crawling, the child is unable to hold a fork, they are simply not developing the motor skills at the rate they should be. Another concern is when you see stereotypic habits, head banging, twitching, things of that sort, which are unusual. And again, parents will often tell you, if the child is banging their head or doing things to hurt themselves, they will tell you about it. Problems in self-regulation is a biggie, and it really has to do with whether or not the child is learning how to sleep, how to behave with other people, how to calm themselves down at the rate that a normal child would be doing so. Self-regulation seems to be an area of particular problems in children exposed to stimulant drugs as well as alcohol. So that and cigarettes as well, we find out recently. So these are areas where we really should be looking. And the other concern is that in families in which substance abuse is a problem, or the family does not have sufficient support, or the mother is under a lot of stress, the child may not have been able to develop appropriate self-regulation skills, so that they are becoming more and more problematic in their behavior due to the inability to self-regulate. Attention problems are things that people typically pay attention to. ADHD has become so widely understood or talked about that people pick that up very quickly. And when the child won't focus on things, when they won't behave, when they're hyperactive, people frequently think the child has attention problems. And they may very well, but they may also have problems in self-regulation or other issues. Behavioral under control or management of behavior is sort of related to the other two that I just mentioned, but this is when the child is just completely out of control and the parent is unable to manage them. And the child, there's just no order or organization to what they're doing. This is going to, of course, make a great deal of problem for this child in their future life and really needs to be addressed. So when I see any of these things, I should have added, I think, in here, although people don't usually pick it up, which is the problems in development of the ability to learn. When you see any of these things, these should make you very concerned, and you should probably make a referral. Where do you send the family when you have seen some of these things? What do you say? What do you do with this? This is a very complicated issue. Well, there are a variety of places you can go, and it all is going to depend upon what you're seeing and how old the child is and what resources exist. And as it turns out, what laws you are dealing with. If there's any kind of medical issues, the pediatrician or medical specialist is the first place to go. If there are any kind of developmental or behavioral problems, the child needs to be seen by a specialist in development and behavior. When you have educational problems, if the child it certainly could be seen by any of the above, but they also may want to be treated through the school system. Social issues, a psychologist, a social worker, or another person of that sort. And then finally, you must often are faced with the issue of whether or not you need to make a referral to protective services. Again, given your work, I imagine this is something you've run into a great deal, but it's certainly something that most of us professionals have to deal with on a regular basis, and I have never found anybody who was very comfortable with it, because it's always a difficult issue and it makes difficulties for the family, unless you handle it well. One of the questions that has recently come up is how to deal with the new regulations that are recently came into effect with the law signed December 20th, 2010, and this is the Child Abuse Prevention and Treatment Act with reauthorization. And previously, the law required reporting of children who were known to be drug exposed, and this was usually ascertained at birth through a urine screen. And it was relatively easy to identify such children, at least through that mechanism. The new policy includes FASD within these regulations, and it appears to me to be focused on newborns, and it requires states to develop policies and procedures to address the needs of newborns who are identified as being FASD. One of the big problems with that is, how do you know the child is FASD at birth? Typically, you are going to be able to identify only the child who is FAS, or the woman who either tells the people at delivery that she drinks, or who comes into the situation with evidence of alcohol abuse. So I think a great many people may not be identified at this point. However, healthcare providers involved in the delivery or care of such infants are required to notify CPS. However, this notification is not to be construed as a report of child abuse or neglect, and it is designed to allow the child to receive appropriate services. All right, when we're talking about evaluation for developmental problems, we should include the following things in our evaluation. The child's evaluation should include a medical, physical, including medical records, evaluation and examination. So when you're concerned about developmental issues in a young child, you really need to start with a pediatrician and make sure that the child is in good health. Or if they are not in good health, find out why. You also want the medical records because you need to know what happened at birth. You need to know how many times the child's been hospitalized and so on. The next thing that's very important, and which we require whenever possible, and this, of course, depends upon the age of the child, is a vision and hearing screen, because many children who, for instance, are language delayed have hearing problems. Or if they are having trouble with motor coordination, sometimes they have visual problems. All of these things are very important, and in families with few resources or where there's a certain amount of neglect going on, the parents may not have obtained these screenings themselves. The next line is probably psychological or developmental evaluation, in which you determine what the child's developmental level is, what their ability level is, and get some feeling for their emotional and social development. If the child's a little older, you're going to want to get an educational assessment as well, particularly if the parent reports problems in school. At our clinic, every child who comes in over the age of 6 is reporting problems at school. That's the area of life in which the child meets the world at that age, and if there's going to be a problem in development, there's going to be a problem at school. Other areas that are very important to evaluate are language. Is the child's language age appropriate? Are there any problems in articulation? Are there any difficulties here that need to be addressed? Another area is motor skills. This is particularly prevalent in very young children when we see them at the clinic, because this is noticeable, a child who doesn't walk on time or has significant motor problems. but there may be more subtle motor problems that need to be evaluated as well. Finally, the area of adaptive skills is important to evaluate adaptive skills, referring to the person's ability to cope with everyday life events. As I said, we should have vision and hearing screens. Screens, usually there's a newborn hearing screen. Most states require this, and most children pass it. This is an acoustical screen where there's a little sound and the child responds. If there is an indication of a problem, people will follow up with an ABARE or auditory evoked potential that uses, during which the child has to be asleep, which uses electrodes in order to identify the efficiency of the brain, of the conducting of sound through the brainstem. And in older children, acoustical evaluation should be done. Vision should be screened by pediatrician or health center. And if there's any indication of problems, which is frequent in children with alcohol effects, more comprehensive ophthalmological examination is indicated. I say it's frequent in children with alcohol effects because problems with eyes are one of the diagnostic signs of this disorder. Children frequently have what's called strabismus. They frequently have what's called ptosis, which is a drooping eyelid. Strabismus is the one of the eyes will not track with the other. This is related to the problems in the eye, which are very frequently seen, and many of children with alcohol effects have visual problems. Medical examination, again, is important. Child should be receiving regular pediatric care, of course, and they should, if problems are noted, refer for consult with a specialist. Specialists that we frequently work with are geneticists in order to differentiate between FASD and genetic disorders, neurologists, because many of the children we see have neurological damage. They may have CP, they may have seizures, they may have other kinds of central nervous system problems. A developmental pediatrician is also an extremely valuable resource because the kind of pediatrician is a specialist who works with developmental problems. Another set of things that may be required in children who are alcohol affected are laboratory tests, and they may include neuroimaging, brain imaging, sleep studies. Many of the children we see have sleep problems, and so there are a whole host of other places that children may need to be referred. Oops, I skipped one. Psychological developmental testing should be done after sensory and medical problems have been ruled out, unidentified or ruled out. They should always be done by a licensed professional who has experience working with the age group in question. So if somebody does not work with infants or preschoolers, you should not be the first one to come to them with such a person, because frequently a person who's used to working with older people is not very effective in working with a very young child. Similarly, you might want to make sure the person has tested an adolescent before you bring a sullen adolescent in for assessment. So you really want to make sure you're dealing with a person who has experience with this population. I think it's important, if you're not sure, to ask questions about their experience and be sure that they will recognize the effects of alcohol and drugs when they see them. Again, not everybody has that experience. Some of these testings can be done through the school system or through other programs in your community. And again, those are questions that you should ask, and there always are problems with resources and how these things can be paid for. So you should definitely check out what resources are available. So I think we're now at the point where if anybody has questions or would like to talk about anything we've discussed, I'll be happy to do so.
Operator, would you like to remind people how to access you by phone, or and also people viewing us on the web, how they can chat in their questions?
Certainly, thank you. Ladies and gentlemen, if you'd like to register for a question, please press the 1 followed by the 4 on your telephone. You'll hear a 3-tone prompt to acknowledge your request. If your question has been answered and you'd like to withdraw your registration, please press the 1 followed by the 3. And also, ladies and gentlemen, if you'd like to ask a question, please use the chat feature located in the lower left corner of the screen. And one moment, please, for our first question. As a reminder, ladies and gentlemen, to register yourself for a question, it's the 1 followed by the 4 on your telephone. And it would appear that there are no questions at this time. Please continue with your presentation.
Well, actually, there are some coming up on the chat.
Okay.
Would you like me to
Yes, absolutely. If you could just let me read the questions off the chat for the sake of the people who are only joining us with the audio. So Jennifer Bailey asks, what are some examples of the sleep problems you've observed?
I could spend quite a long time talking about sleep problems we've observed. When I started working with kids with developmental disabilities, it took me a little bit of time to realize that sleep problems are one of the major things that people came in with and never mentioned. And we'd see families in which everybody was totally exhausted, and after a while it dawned on me that they weren't sleeping. So what we see are every imaginable kind of sleep problem. Sometimes, if we're talking about a baby, the baby has never slept through the night, and they are now 2 and a half, and they still get up 3 or 4 times a night. Sometimes we're dealing with a child with respiratory problems, and respiratory problems are very frequently associated with sleep problems. And again, that's a question you should always ask when you hear sleep problems, and the child has asthma and so on. These are terribly interconnected. The other major problem that most people think about when they think about sleep problems are whether or not the parent has really helped the child develop appropriate sleep hygiene, we call it. Because many times if you have a sort of a disorganized family or a family which doesn't have a private place for the child to sleep or something of that sort, the child may not have learned how to calm themselves down and fall asleep, and they might just simply stay up until they collapse somewhere on the couch. So you have to ask a number of questions about the environment. But we see problems with sleep initiation, which is getting to sleep. We see problems with not maintaining sleep, waking frequently during the night. Some of the kids wake in the night screaming. Some of them refuse to sleep anywhere but with their parents. I mean, pretty much every possible variety of sleep disorder.
Dr. Coles, there's another question. Nicole Russell asks, how do you take into consideration the assessment for adoptive parents that have no contact with the birth family and nothing specific in the history, just some narrative stories?
That's, of course, one of the most difficult issues that we see in trying to decide whether or not the child's been exposed to alcohol or drugs is what to do about the family, either with adoptive family or foster care. And really about 70% of the children we see at our clinic are either in foster care or adopted. What we do, and there's no easy answer to this at all, there's no magic. What we do is try to get as many records as we can. We try to get birth records. Often the hospital record will include information about whether or not the mother was positive for substances at birth or whether or not she reported using alcohol. We try to get social service records because frequently when we have a family that's been placed in care or a child's been placed in care, there will have been a evaluation of the family before this occurred or as part of the process, and that will describe the mother's history of substance use. Sometimes we don't have any of that. In that case, we're sort of going along by whether or not the child has the physical and behavioral characteristics associated with the disorder. most of the children who end up at our clinic are coming out of and who are referred by the foster care system and so on. The foster care workers, have an idea about the exposure, and that's why they're referring them. I think something like 70% of the children coming into care in Georgia, and I'm sure this is the case elsewhere, maybe more in some cases, have substance abuse as one of the problems in the family. So there's just such a high percentage that it's like a red flag. When we're trying to decide whether or not we can say that the child was exposed, we have a list we go down, and we go, was the mother arrested for DUI? Was the mother jailed for selling drugs during pregnancy? Was the mother a registered alcoholic in Russia? Did somebody that a reliable person witness her drinking during pregnancy? I mean, we do not take rumor, so sometimes we really don't know.
Dr. Cole, this is Jean. I just wanted to alert you to the fact that we're through about a third of the slides and half of our time.
Okay, well then I'll talk faster. How's that?
No, what we might want to do is possibly think about just having one Q&A period more towards the end. But let's see how far you get.
All righty.
All right.
All right, let's talk about how we diagnose FAS. This is FAS I'm talking about here, not FASD. This is the full syndrome. But FASD, fetal alcohol spectrum disorders, is diagnosed using these same kinds of, trying to get my pointer, that's not the pointer, these same kinds of things. There are 4 criteria. One is alcohol exposure, and that I was just talking about. The second is the face, having the facial features associated with the exposure to alcohol, and that's what this slide is about. The third is growth, having evidence of growth deficiencies either at birth or later. And finally, the fourth is having some effect on the brain, which is manifested as developmental disabilities, learning problems, behavior problems. You will see in this picture, which is this little girl here, the characteristic features associated with FAS. There's microcephaly, low-set ears, small palpebral fissures, which is the opening of the eye, a flattened nasal bridge, absent or indistinct philtrum, which is little grooves in the top of your lip, and a thinned and flattened vermilion. And I would like you to look at the other children in the pictures. Here's a little boy who has the same features. He's African American rather than Caucasian, but he has the same pattern of features that I just described and pointed out in this little girl. And here's another little girl who's Russian, and she once again has exactly the same features. These are the characteristic features that allow us to diagnose FAS. We have diagnostic criteria that you may not be able to read. I hope that you can see it a little better than I can on this slide. But the first, when we do our diagnosis in the clinic, we go over alcohol exposure, the things that I mentioned before, growth deficiency, and the child has to be under the 10th percentile, either at birth or later. Then we ask about dysmorphia, and that is the facial features I mentioned, as well as some other features like curved fifth finger or very small nails. And we get a score. We have a checklist. We get a score from that. And finally, evidence of damage to the central nervous system, which is obtained through the psychological evaluation. Now, if you have all of these, you've got a diagnosis of FAS. It is possible, using the IOM criteria, and that's the Institute of Medicine and the CDC's criteria, it is possible to have no evidence of alcohol exposure. If you have the other 3 very clearly, then we assume the alcohol exposure. However, if we do not have the alcohol exposure information and we do not have all 3 of these others, we will not make a diagnosis of FAS. We cannot make a diagnosis of FAS because we're really not sure. Generally speaking, in our clinic, we don't use behaviors such as active testing out behavior or ADHD or anything, or mental health status as a criteria, we use things like IQ, deficits in graphomotor performance, specific deficits in certain academic skills as criteria. FASD, which is on the spectrum and not the full syndrome, can include alcohol exposure plus CNS damage without the other physical features. Developmental problems. This is a delay or abnormality in the normal developmental process. So, for instance, the child does not walk by 18 months, the child does not speak by 2 years, the child cannot learn to read, or the child may have an abnormality, being uninterested in social contact, has normal language but can't write. These are developmental problems, and those are the kinds of things that we use to satisfy this last criteria of neurodevelopmental deficits. One of the things that we have observed over the years in FASD is that a child may have problems in all of these areas, and they may persist throughout their lives. Physical, health, and motor skills, developmental cognitive, behavioral and social skills, and later, as they get a little older, academic and vocational skills. And when we're assessing a child, diagnosing it, we have to look at all of these things very carefully because each one of them might be a problem. In doing so, we use standardized testing, which have established a developmental level. We look at adaptive functioning, and we look at the child's behavior in relation to age norms. We look at how they interact socially. It is even possible to assess newborn babies, and I've assessed quite a few of them for the effects of alcohol and found that we could predict which children were going to have problems when they were teenagers based on the behavior of 3 days. So you can do it. I don't know if the word complexly is actually a word. But anyway, it doesn't look right. But there's a lot about a baby that can be used, newborn, that can be used to assess outcomes. When we're assessing an older child who is between 0 and 3 years old, we will use what's called a developmental test. Otherwise, we will use a test of ability, which are generally referred to as an IQ test. Another area that we're very focused carefully on is adaptive and self-help measures. If you're trying to make a diagnosis of a child and you want to determine whether or not they have a deficit that will qualify them for services, either educational or otherwise, the child must have deficits both in their intellectual ability and in their adaptive functioning. And one of the most widely used tests here is the Vineland Adaptive Behavior Scales, which goes from 0 to 18 years old, and looks at whether or not the child's communication, daily living skills, social skills, and motor skills are developmentally appropriate. And then we can compare how their adaptive behavior relates to their intellectual abilities. Children who have significant social problems or who are living in environments where they are abused and neglected will often have adaptive behavior deficits even when their cognitive behavior or their intelligence is relatively normal. One of the important questions when we're looking at the effects of alcohol is that we get different presentations by age. This is just natural given that children are different at different ages, but there's particular things we look for. In newborns, we look for disturbed sleep patterns, hyperreactivity to stimulus, high activity level, gastrointestinal problems, and sometimes neonatal withdrawal syndrome. In infants, we see medical problems, developmental delays, feeding, GI problems, sleep problems, motor problems, respiratory distress, and otitis media or ear infections. In preschoolers, usually we see language delays, often behavior problems, frequently effects of abuse and neglect, and as I mentioned, frequently sleep, sensory problems, a lot of asthma. When we're talking about the behavior characteristics and just characteristics in general that make me concerned, this might be FASD, will be the social caregiving problems, medical problems early in life, motor, cognitive, arousal regulation difficulties, and lack of access to treatment and intervention. Do you want me to skip this next question period?
Actually, actually, we have a question. Since we have a question in the chat room, let's just address that very briefly. So Deborah Barnes and Josiah, I hope I pronounced that correctly. How acceptable is it for hospitals to say that the facial and other manifestations of FAS are not sufficiently developed at birth for a reliable diagnosis? I'm assuming that again, has to do with referral to CPS.
Yeah, that's an interesting question. As I said, we were able to identify children pretty accurately, although we were aware that at newborns, although we were aware that the mothers were drinking, or we were aware that some of the mothers were drinking, we did it blind, but so that we knew there wasn't something else. But some of the dysmorphic features, and if the dysmorphic features are present at birth, they certainly should be cause for referral to genetics, because it's either FAS or it's a genetic disorder or it's exposure to something else. And all of these things are red flags. So I would say it's not acceptable, although it's very common. And whether or not they're not sufficiently developed, they are sufficiently developed. It's just that most people are not aware of it and not trained in it.
Sounds good.
Okay. Anything else? Okay, then I'll proceed. In our clinic, do you want me to? Okay, I'll go and we'll have another period. These are the services that we recommended after diagnosis in infants that we saw at our clinic. Here are the blue bar is children who were not exposed to alcohol, or we couldn't identify any alcohol exposure. The yellow bar is children who were exposed to alcohol but did not have a diagnosis of FAS or DFAS, which is partial FAS. The green bar is partial FAS, where they had some of the criteria, and this bar is those who met full syndrome. And as you can see, for the medical, there were not a lot of medical referrals done, often sent from labs, and that refers to usually a genetic screening. Some children referred for MRI, and some were sent off for consults with other doctors. Many children were sent for speech therapy, occupational therapy, and physical therapy. I'd say speech and OT were most common. These are babies. Finally, for early intervention, we sent lots and lots of people with FAS, and then a number of children were sent on to special needs preschool. School age. Most of the school age kids we see get referred for behavior and school problems. The additional problems we see include mental health issues, ADHD, anxiety, depression, effects of abuse and neglect, of which we see a great deal. Over-medication is a very common thing, and I can talk a little more about that, but there is no really good medication for this disorder, and as a result, people tend to try everything, and children will often come in on 5 and 6 medications, which isn't really a good idea at this age. Kids frequently have specific learning disabilities, and often they've had a difficult environment, which has caused problems for them. We do get sort of a pattern of referrals with different types of groupings. So we get one group who have intellectual disabilities with IQs in the mildly mentally delayed range. And they often will have significant physical findings, which is to say physical facial features. There's another group who comes in with borderline IQ, which is 70 and above, who often have a history of foster care and specific learning deficits. This group may have a lot of behavior problems. The third group we see a great many of are international adoptions, and these kids come in often with attachment problems, having spent a good deal of time in an orphanage, and they seem to have more frequent specific language disabilities, and that may be because English is not their first language. Finally, there's a group who come in with what I would call nonverbal learning disabilities, and this is where they have a relatively preserved language ability, but a really significant problem with nonverbal skills. And this means people who have a nonverbal learning disability often appear to be, because their language is adequate, appear to be higher functioning than they really are, and they often have really significant problems with mathematics, with social perception and getting along with other people, and they will frequently described as clumsy. And it's sort of a hidden disability, but one that we see really often with this group. The additional services recommended at school age tend to be, for the behavioral therapeutic, to the support groups for parents, psychotherapy for everybody, parents and children, and then a lot of behavioral management. We also refer a lot of kids to preschool and after preschool to special education. In adolescence, you get a whole different set of issues. And these kids tend to be referred for behavioral, school, social, substance abuse, and legal problems, which is a lot of problems when you think about it. They often come in with cognitive deficits, frequently unidentified. They have problems with executive functioning. Executive functioning is the frontal lobe function in the brain, which allows you to plan, organize, delay gratification, behave like an adult, in other words, and this seems to be an area of specific deficit in FASD. You see educational and vocational underattainment in older adolescents. A lot of social skills problems in which they just simply, it's not social in that they don't want to be with people. Most people with FASD really do like other people, want to be with them, want to interact, but they don't seem to be able to do it very efficiently. Conduct problems are frequent, and whether the conduct problems result directly from the alcohol exposure or whether they come from a history of poor environments is anybody's guess, and probably is a combination of both. A number of kids have psychological and psychiatric diagnoses. Sometimes they have substance abuse problems, which should be no surprise to anyone given that they come from families where this is a significant issue. And finally, a number of the kids, by the time we see them, have already had legal problems. Sometimes it's skipping school, sometimes it's stealing things, sometimes it's more serious problems. So, what do we do? What are the potential interventions for FASD? And it used to be, not very long ago, that nobody had any idea the answer to this question. We used to throw up our hands and say, nobody knows what to do, and really no one cared, I think. The IOM, the Institute of Medicine, in 1996, suggested pretty strongly to Congress that they should do something about this, and Congress gave money to the CDC and to set up some, to do some research and interventions, which they did, and since that time, NIAAA has also done that. There's the things one could do for a person who has FASD is change their environment, institute a therapeutic intervention with a child and with a family, help in developing their skills through programs, arrange for early intervention or educational interventions, and finally, provide appropriate medications. So I'm going to talk to you a little bit about each one of these areas. Only a little bit. There's not a lot of known. Now, the service needs of alcohol-affected children, as I mentioned above, tend to be, these are behavioral kinds of needs. There are lots of behavioral regulation problems. Many of the kids have been victims of physical or sexual abuse or neglect. Many have had multiple placements within the system. A third of the children who come to our clinic are on behavioral medications. And then there's certainly evidence that prenatal alcohol exposure may disrupt normal arousal regulation. Another question is learning problems, so we need psychoeducational assessments. There needs to be help with designing educational programs. There often needs to be individual occupational therapy and tutoring services. And we need to have parents trained to partner with the schools in furthering the child's education. We at our clinic are fortunate to have a special educator who works on all of these things, and I just think that's a terribly important part of helping kids with FASD. Another area that's important is social supports and assistance in linking with community resources. And again, this is where social work comes in, or people doing social work because so many of the families need a whole lot of support in order to be able to function at their optimal levels. Unfortunately, there have been a lot of myths that interfere with treatment of FASD, and one is the question that was referred to earlier, and that is you can't identify FASD during infancy, and I really think that you can. Another one is only certain types of people have FAS, and one of the capital law, when I was reading it, it stated that FAS was much more common in minority populations, which I don't really think is true, but it certainly sets up a stereotype such that people might not look for it in other groups. It also tends to make us think that we don't have to be concerned about this because it doesn't affect people like us or whatever. Another myth has been that children with FASD can't learn, and it doesn't matter what you do, they have brain damage and they can't learn. They don't generalize is another important thing that people say. Well, you can teach them something, but they're not going to remember it, and they can't remember it the next day, and they don't use it in other situations. Behavior modification doesn't work. I've heard that many times. It doesn't, I've tried it, doesn't work. And it works on everything. It works on lower organism, works on planaria, it works on everyone. So that really isn't true. They all have ADHD. They don't all have ADHD. That's a whole other lecture, but they have something, but it's not really ADHD. And another one you'll see if you go on the internet and people come into the clinic all the time quoting this, is they can't understand cause and effect. And I don't think people who say that really recognize what they mean. I think what they're referring to is the executive functioning problems that people often have with FASD. But I say to them, does he know to turn on the lights when he goes into a room? They say, sure. I said, well, in that case, they understand cause and effect. What you're concerned about is they're not able to delay gratification and wait until much later to get something because they're not thinking and able to show that kind of self-regulation, which is a different issue. So when you're deciding to make a referral, you have to think about certain things. You have to decide what is the status, who's the child living with? Is this the birth parent? Is this the foster parent? Is this the adoptive parent? Is it the grandparent? What kind of resources are available? Are there any health problems that may interfere with treatment or which require immediate treatment? What is the child's developmental level and in what areas? So what are the issues that need to be dealt with? And finally, what are the family and community resources? What does the family have to bring to this? And what is available in the community to help? There's a number of barriers that people have identified in treatment. Finding other service providers who know about FAS and about the targeted interventions can be a huge problem for people wanting to get help for kids with FASD. And because frequently there are no one available who has these skills. Another problem is fitting the child with FASD into the existing diagnostic schemas and categories. There is a specific statement in the IDEA law saying that individuals with autism should get services, but there's nothing there that says people with FASD should get services. And you then have to find some category into which you can put this child. Sometimes we get in the educational system designate the child as OHI or other health impaired, which means that they can get services in that manner. And then you run into the mental health versus the medical issue. Mental health services cannot be obtained under the medical diagnosis, which is 760.71, which is the FAS category for medical diagnosis, but because you have that does not guarantee you any mental health services, so that you then have to have a mental health diagnosis. We know that the best intervention for someone with FASD is usually a hybrid, a combination of cognitive therapy and educational services, or for instance, and you often have to find a way to get that hybrid. Another barrier may be the significant social, caregiving, and environmental problems that may exist in families in which FASD is a problem. And so you may find that you need to deal with the issues that are presenting in the parent and support the parent sufficiently to allow the child to receive services. You may also find that the child who's in foster care may or may not. Sometimes they have wonderful foster parents who will do anything, and sometimes you have a foster parent who's not really totally concerned with the special needs of this child. So you have to figure out what's going on within the family. Anne Streisguth in 2004 published information about how environmental factors contribute to child outcomes in individuals who have FASD. And she said that you've got better outcomes under these circumstances when the child experienced a stable, good quality home, when they stayed in a living situation for an average of more than 2.8 years, which just seems awful to me because that's such a short period of time. But if the child had anything resembling a good quality home, they did much better. If they had their basic needs met, their outcomes are much better. Again, that's not exactly news, I guess, to any of us, but it points up how important such things are with this group of children. Never having experienced violence. Again, obvious that that's much better for you, but it's important when you consider the meaning of it in this context. Early diagnosis. The earlier the child was diagnosed, the better off they were. And having a diagnosis of FAS rather than TFAS or FASD resulted in a better outcome in terms of social factors. And that is probably because people with FAS actually were qualified for services, where most people with FASD were not. Having received services, if the child was eligible for services, then they were much more likely to have a positive outcome than otherwise. Another very important question is, are there any evidence-based interventions for FASD, and what do we know about them? Well, we don't know much, because as I mentioned above, this has only recently been an area of focus. But I'll summarize briefly the findings up to this point. And I do want to mention that these are mostly about school-age children. There's almost no published research on infants and toddlers or adolescents. There's a paper by Teben in 2009 that comments, and these people who are in Australia reviewed the existing literature at that point and concluded that there are successful interventions for people with FASD, and they target specific clinical and neurodevelopmental deficits. So they would identify the deficit or the problem and specifically focus on that. That the pattern of hyperactivity or arousal dysregulation that you see in FASD seems to be different from that seen in ADHD. And that's an important point, because when you treat somebody for ADHD when they don't have it, you may not have a positive outcome. And they also noted that many healthcare professionals perceived that there were no effective interventions for this group. Another person who reviewed the literature was Jacqueline Bertrand, and she, from the CDC, and she noted the following, that in reviewing the interventions supported by the CDC, we found that the existing methods that are used with other children can be and must be adapted to the special needs of the individuals with FASD. So you can take a known treatment and modify it somewhat and use it with someone with FASD. That intervention and treatment can be provided within existing service networks. It just depends on choosing to do so. One of the things that we found in doing these studies where the caregiver involvement was necessary, that we had to have the parents involved in supporting our work. The parent was one of the focuses of the intervention, and that our goals were to improve parental knowledge of FASD and provide those parents with the tools to support the changes in behavior that were necessary. This is a huge, important point. And also found that with working with the children, explicit instruction was more effective. Most of the time, we assume that children are going to pick things up from living in the world, And we found that with children with FASD, this was not the case, that you needed to, if you wanted them to know something, you needed to tell them that. You couldn't just hope that they would pick it up. So that children learn new skills better with explicit and focused instruction. Drug treatments. Everybody would like very much for there to be a drug treatment for behavioral problems. But at the moment, here's the situation. There are a few drug treatments that have been tested for FASD, at least formally. They're frequently given to children with this, but there haven't been formal clinical trials for the most part. Children with FASD do not seem to show a unified response to drugs consistent with the response shown by other groups of children. So that one child may be positively impacted by Ritalin, for instance, another child may show a really negative response. Providers usually treat individual problems as a result, and the small amount of empirical research available does not support the idea of using stimulants to control behavior in this group. Successful intervention strategies for FASD have been the following. Early diagnosis and treatment seems very important. Secondly, it's important to deal with the individual child. Alcohol exposure causes a wide variety of outcomes for many reasons, but also because there's so many different patterns of exposure and abuse in the individual and so many contributing factors. So that each child must be seen as an individual, and they must be individually assessed and individual programs designed. We have found that educating parents about the disorder and about the fact that it comes from the brain, that there's a neurodevelopmental insult that has caused the child to behave the way they are, is very important. That way we can get away from thinking of the child as bad or naughty or non-compliant and think of them as someone who has a disability. It's important to educate interventionists about this disorder and its characteristics in just the same way that it's important to educate parents. We found that when we went to the schools and worked with the teachers directly and told them the same things we're telling the parents about the brain base for this disorder and how that was manifested, that we got much better outcomes for the children because we got the teachers working with us rather than seeing the child as in a negative light. Another important factor was helping children learn to control their own arousal levels, develop self-control and self-regulation. That made a huge difference in getting them in a situation where they could learn and control and interact in a more positive manner. We found that basic behavioral learning methods, which stimulus response, behavioral modification, and so on, works just fine. There's no reason to be concerned about that. If you put the child in the right situation and if you actually implement these programs appropriately, they work. We also found that specific skill building, sitting down, teaching the child a specific skill, and we've done everything from teaching them how to cross the street, to teaching them how to leave the building in a fire, to teaching them how to do math, were very effective. And other people have done social skills programs and programs for monitoring executive function problems. What is needed in the future? Well, again, I want to say it again, early diagnosis and doing what's necessary to help that baby, allowing the child to be in a stable environment and supporting stability in the environment, developing and implementing focused treatments that take into account specific characteristics of FASD, making sure the caregiver is involved and supported in these interventions, educating educators and healthcare professionals and providing them with the tools that they need for implementing effective programs. We can't really fault people for not doing what they don't know about. So we need to make sure that the people who are working with children understand the best way to help them. And we probably need to go out and change the education and social service regulations to include FASD as a category qualifying for care and supporting families who are trying to help children with FASD and supporting people like you who are trying to make a difference for these children and their families. Okay, now back to questions.
Thank you, Dr. Qualls. We have a question in the chat room, And operator, are you still with us?
I am, yes.
Would you like to announce again how our audio folks out there in the audience land can access us?
Certainly. Ladies and gentlemen, again, as a reminder, if you'd like to register for a question, you'll need to press the 1 followed by the 4 on your telephone. And if you'd like to register a question via the web feature, please use the chat feature located in the lower left corner of your screen.
Thank you very much. So we have a question from Deborah Barnes Josiah. The question is, in your expertise, your opinion, is the ability to delay gratification something that is learnable in these children? Perhaps teachable, learnable?
Yeah. Well, yes, it is, I hope, because we're in the midst of doing a clinical trial on it. We developed a program called GoFar, in which we have a computer program which involves a little guy in a spacesuit who is learning how to focus and plan, act, and reflect on, which is FAR, on what his actions are in order to delay impulsive responding, think about the possibilities in the situation, and then think about how they achieved what they actually achieved. We did find in a previous study, which is called the MILE study, which was designed to teach children mathematics, but turned out to be teaching them impulse control and mathematics. We found that we really could teach children strategies for approaching a problem more effectively and learning how to control themselves. There are a number of other programs out there, some of them done by Bill Diamond and her group, that have looked at ways to teach preschool children and young school-age children how to exercise executive functioning skills, how to not just respond, but to respond appropriately. So I really do believe it's possible to teach children to do this.
Thanks. Are there other questions from the audience?
Or comments.
And we have no questions on the audio portion.
I have a question, Dr. Coles. Most of the programs that I'm most closely affiliated with are the AIA projects throughout the country that are working with client populations that I'm sure there is FASD in these families, as well as substance abuse. If I was a program provider and I was in the midst of doing having developmental assessments, would I automatically be likely to have someone tell me that they're picking up FASD in addition to other substances, or are we really talking about bridging these two worlds?
Oh, I don't know if I can answer properly. I think that there's a great deal of undersensitivity to the issue of FASD. I think people often do not recognize it, even when you would think logically they would. And one reason I was interested in doing this webinar is to be sure that that people are thinking in these terms. And we recently did a project with 0 to 3 people too, for the same reason, to try to get people thinking about the fact that they may be dealing with FASD among substance abusers, as well as in their children. And I don't know if that's the question you were asking.
I think it is. I think what I'm trying to wrap my head around, and not doing direct practice myself, and being slightly removed from that process, I'm just trying to see, the descriptions of the children are very, very similar to what you would see in other populations where other substances have been used, and so
they're all together.
Yeah, so I'm trying to think about what the implications of that would be for the interventions.
Well, again, that's why we need to do an individual assessment of the child. But, when you're talking about someone who's been exposed to cocaine, they've usually been exposed to alcohol.
That's right, all the multi-drug use. Yeah, multi-substance.
it's not sensible, I think, to think in terms of, this is a child exposed to heroin or this is a child exposed to methamphetamines. They're exposed usually to a whole multitude of drugs.
That's right. And then the inference I take away from this is that it's important, though, to because there's all the poly drug use, it's very important to broaden the assessments, if you will, in order to look for something as common as alcohol.
Right, you really should. And it's hot. People don't pick it up because there's no urine screen for it, and so the woman will say, yes, I was using cocaine and marijuana, all of which came out in the test, but I didn't drink alcohol. And I'm thinking, really? Is that likely?
That's right. That's right. Okay. So are there any other comments or suggestions that people have or last-minute questions?
It would appear that there are no further questions on the phone lines.
Okay. Well, if you feel that you've concluded this, Dr. Coles, then I want to...
Somebody says they have one more. Julie Payne.
Okay. All right. We'll wait for that in the chat room here.
Maybe not.
No, it's probably just a long question.
Okay.
Okay, here it comes. What is the long-term outcome of children who have been diagnosed with FAS when they become adults? Do they need ongoing assistance throughout their lifetime?
Oh, that's a wonderful question and a very complicated one. We have some people that we've been following since 1980, which is a long time ago now. Tells you how old I am. And some of these people were very much affected and some were more mildly affected. And most of them came from low-income backgrounds, so that they were socially at risk to begin with. It's rather astonishing, the range of outcomes. Some people are in jail. Some people graduated from Princeton. So it's just been a very wide range. And I think there are many reasons for that. Certainly it's people's natural genetic makeup, and some people are more vulnerable than others. But I also noticed that there are environmental factors and there are interventions that some people appear to have been well supported and had good lives, and other people haven't, and those things made a huge difference. It's just, you've got a person who's very, very vulnerable and may have neurological damage. And the problem is that it's hard to define because it may be a lot of damage or little. And then you put them in some kind of environment, and the very vulnerable person is going to be much more affected than another person. And the very resilient person perhaps will not be. So it's quite complex. So I guess I have seen children that we've worked with over the years do much better than I would have anticipated them doing if they had good supportive environments. So I don't know if that answers the question completely, but it does seem as though you can really make a big difference with this group of people if you can help them get what they need.
That makes good logical sense. I mean, that's what we find with the entire population of those exposed to substances. So I think that we've been seeing that. Okay, well, taking a look at the clock here, I want to thank you, Dr. Coles, very much.
Oh, you're welcome.
It was very informative, and it's great to get that information out there. I also want to thank the participants on the call. There were some excellent questions, and I really appreciate people signing on. So we very much value the feedback that we receive and take it very significantly frequently and pass it along to our presenters. So please, we'd like to urge you to take a couple minutes and fill out the form that is an online evaluation form so that we can continue to make these trainings better and better. I thought I would also put the word out there that the AIA Resource Center is just announcing a conference that we're going to be holding in Austin, Texas next September. I hope the weather cools down a bit, but next September, a year from now, we're having a conference that is one that we had in 2008 called Strengthening Connections, and it really focuses on how we can increase the parent-child attachment in families that are affected by HIV, substance abuse, and trauma. So we're taking a look at the evidence-based programs and promising practices in working to promote attachment. And we're hoping that people will join us there in Austin next September. And there will be more information about this on our website. I know that we've chatted with a number of you, telling you that the slides that Dr. Coles presented today will be up on our website. Just give us a few days to get those posted, but they will be up there for download and for printing purposes. The other thing is that I wanted to mention that we always tape these teleconference calls to make them available on our website for others to hear. So this particular tape is being called. This particular call is being taped today and will be on the website. So, Dr. Coles, thank you again. We really appreciate your time and your effort.
I'm happy to do it.
Hope to work with you again. All right?
Thank you.
Okay, thank you all.
Bye-bye.